Thank you so much, Katie. And we're just going to go ahead and jump right in. And I'm going to start off by saying that ethical issues may arise with pretty much any patient encounter, whether you are a student or you're a clinician. In the majority of cases, the ethical choice or the decision regarding ethics is pretty clear. Unfortunately, there are some situations that can become complicated despite your best intentions. And that applies even if you're a PA student or a new grad. So like Katie said, my name is Janelle Bludorn, and I am faculty at the Duke University PA program. I'm also an emergency medicine PA. And today I'm going to share with you when good intentions go bad, stories in medical ethics. Maybe I will. My slide skipped. So you all probably remember learning about medical ethics in your professional practice class during your first year of PA school. You know, memorizing all those definitions for things like autonomy and justice and the surprisingly difficult to pronounce words beneficence and non-malfeasance. And if you don't remember that among the deluge of like pharmacology and clin med and OSFEs, you certainly remember reciting an oath written by this guy, Hippocrates, during your white coat ceremony, which basically boiled down to do no harm. And although Hippocrates gets a ton of credit for medical ethics, and let's be honest, he gets credit for a ton of things, being the father of modern medicine and all, medical ethics as we know it today is actually a pretty young concept. Although Hippocrates planted the seeds for this back in the 5th century BC, and the American Medical Association adopted its Code of Medical Ethics in 1847 based on the works of physician philosopher Thomas Percival, it's actually pretty important to note that up until the 1930s, medicine was wildly paternalistic. So that means that patients didn't really have that many rights. They saw the doctor and they were told what to do, and sometimes they were even subjected to experimental interventions without any knowledge or without their permission. So it wasn't really until after World War II when the world learned about the horrors faced by people in Germany of forced medical experimentation and worse in concentration camps that prompted the Nuremberg Code, which is considered by some to be the dawn of modern medical ethics. Even in the decades following, change was pretty slow to occur, though, with unsettling examples such as the Tuskegee experiment as recently as the mid-1970s in the United States. In the 60s and the 70s, there was a newfound emphasis on patients' rights, including individuals having a say in their clinical course, in their privacy, as well as in their permission. So this new ethical standard in medicine essentially said that patients generally know what's in their best interest, and it discarded the notion that the doctor, or in our instance, the PA, is automatically always right. But of course, there is a lot of gray area in medicine. Obviously, you learn in PA school that caring for patients is not like black and white. I mean, this is illustrated by those multiple choice questions that are like, choose the next step that's best in the treatment for this patient. And like 3 of the 4 options are correct. You have to like figure out which one is the most correct. We all know those type of test questions. Some of us write those test questions. And medical ethics is kind of a lot like that, actually. Except in medical ethics, sometimes there are no quote unquote right answers, but maybe the least wrong answer. And even though throughout the course of this session, you might disagree with me and feel that an individual acted ethically when I feel that they didn't, or you may disagree with my take on which ethical principle an individual infringed, and that's okay. And why is that okay? It's okay because gray area, and it exists in medicine, and it obviously is going to exist in medical ethics too. So for a lot of people, medical ethics is seen as a bunch of rules that kind of tell you what you cannot do or what you should not do. However, I encourage you to look at them with a more positive or proactive connotation, specifically the 4 major principles of autonomy, justice, beneficence, and non-malfeasance, and look to these as guides to sort of back you up, like basic tenets that you can apply to any number of unique situations to ensure that your decisions and your actions are ethical. And sometimes, despite having the best intentions, medical learners, including all of you as PA students and lifelong learning PAs, You may unintentionally make mistakes or find yourselves in the position to do so that kind of go against the principles of medical ethics. And that's what we're going to focus on tonight. So now that you know a little bit more about the history of medical ethics, let's turn to the objectives for the remainder of this session. We're going to be meeting 4 bright individuals at the beginning of their PA journeys. Some are students, some are new grads, but each is going to be facing an issue with medical ethics, despite setting out with the best intentions. Through the series of these cases, we're going to define the 4 major principles of medical ethics. And again, those are justice, autonomy, non-malfeasance, and beneficence. As we've already mentioned, we're going to be describing situations in which these PAs or PA students may face ethical dilemmas, each of which may be situations that you very well may find yourselves facing when you're on clinical rotations or in clinical practice. And finally, for each case, we're going to explore ways to guide you when determining the most ethical decision and then acting on that decision, especially when it might be a little bit tricky or a little bit difficult. So as Katie said at the beginning of the session, for those of you who are joining live, we are going to be using Zoom polls for anonymous participation during this session. We're going to allow for 20 seconds of response time for each multiple choice question. The answers are going to be revealed as each case continues to unfold. And for some of the questions, there may be one of those like quote unquote most right answer, as ethics is not always clear cut. I will not be monitoring the chat for questions during the presentation, like Katie already said, but you are more than welcome to submit questions that are going to arise in the Q&A box, and we're going to try to address those at the conclusion of the session. So let's begin with Cecile and her story. So Cecile is a second-year PA student who is a hopeful dermatology PA in the future. She's also a budding medfluencer with a sizable following across social media platforms where she shares her experiences from PA school and some educational content. On her dermatology elective, she was so inspired by a case of a young woman about her same age whose friend noticed a suspicious lesion on her back while she was shopping. So the lesion ended up being melanoma, and Cecile was involved in this patient's care from her very first clinic visit all the way through excision and now at her post-op follow-up visit. So in an effort to raise awareness of suspicious skin lesions in young women and the management of melanoma, Cecile posted some images of the patient's lesion pre-op, intra-op, and post-op with the caption, "It's good to have friends that have your back, so inspired by the positive outcome for this patient and her melanoma." She was super careful not to include any images of the patient's face, nor her name, or any other obviously identifying information. Cecile received a ton of likes and comments, including a comment from the patient who expressed a little bit of displeased surprise to see her story shared while she was scrolling through social media. So now I'm going to invite you guys all to take a moment or two to ask yourself while Katie pulls up our Zoom poll. Do you think Cecile reached any medical ethics principle? And if so, which one? Options are yes, autonomy, no, but she violated HIPAA, yes, justice, no, she acted ethically. Okay, thank you. We saw our answers here. It looks like 59% of you say autonomy, 20% no, but she violated HIPAA, 8% yes, justice, and 14% no, she acted ethically. We'll stop sharing that here. And Katie, maybe stop sharing the poll, I think, and we'll move on. And we're going to chat about autonomy for a minute here now. So autonomy is often thought about the patient having the right to make decisions about their own workup, their treatment and management without coercion or without any coaxing. And this is where the concept of informed consent fits within the realm of medical ethics, as this process requires a clinician to ensure that a patient understands the risks, the benefits, and the alternatives to any particular test or intervention. That is informed consent. Super important concept for you to understand as a clinician or a future clinician. However, autonomy also applies to what happens to patients' health information, including, as we heard about in Cecile's case, depiction of a patient's medical condition, including actual patient images on a public digital platform. And I know that we see this kind of stuff all the time, ranging from academic offerings like #FOAMed or free open access medicine to guilty pleasures like Dr. Pimple Popper. I'm personally a fan of that. However, without a patient's informed consent to share their stories and their images, even if it's anonymous, the patient is stripped of the autonomy over their information. So in this instance, I would say yes, that even with the best intentions of sharing and inspiring an educational story, Cecile's actions were unethical. But, it's not too late to make it right. So if you were Cecile, kind of reflect for a moment here and think about what your next step might be to make this right. So here is what Cecile did. Upon realizing her mistake, she removed her post and she let her preceptor and her program know of her misstep. Surprisingly, neither of them were too upset, and both her clinical coordinator and her preceptor shared instances of times that they too made similar mistakes. They thanked her for her honesty, for doing the right thing, and her preceptor explained to her the process that their clinic uses to share patient cases online using informed consent. So although she was embarrassed, this mistake helped Cecile realize that there's a lot of gray area in medicine, that she was not alone, that everybody makes mistakes, and that it's always okay to ask for help when you find yourself in a tricky ethical situation, especially if a mistake has already been made. So now let's meet Sebastian. So Sebastian is an aspiring orthopedic surgery PA who's on his elective rotation with a world-renowned orthopedic surgeon who treats some big name athletes and is notoriously hard for patients to get an appointment with. Sebastian's dad had a bad knee for some time now, and his dad is in the market for a joint replacement. His dad's been kind of managing conservatively with physical therapy and some joint injections under the guidance of another orthopedist who has arranged for Sebastian's dad to have a knee replacement next month. However, Sebastian wants his father to be operated on by the best, and so he suggests that his dad tries to make an appointment with the world-famous surgeon that he's currently on rotation with. The issue is that the next available appointment is 6 months away, which is a long time when you've got bone arthritis, desperately in need of a knee replacement. Well, Sebastian hears of a cancellation in clinic for tomorrow, and he asks the scheduler to slip his dad into that appointment slot ahead of other patients who are in the queue. He figured that it'd be a win-win. His dad will be seen sooner by this top-notch surgeon, and there's not going to be a hole in the clinic schedule tomorrow. So, hearing all of this for question number 2, what are your thoughts on Sebastian's actions? Did he cross any lines in terms of medical ethics? And if so, which ethical line did Sebastian cross? You see that the poll is up here, maybe. Okay, I think that is the end of our 20 seconds here. Looks like most of you, greater than 50% of you, are saying justice, about a third of you are saying beneficence, and about 10% of you non-malfeasance. None of you think that it's autonomy, really. So justice. According to the American Academy of PA's guidelines for ethical conduct for the PA profession, justice means that patients in similar circumstances should receive similar care. So there's kind of like an obvious and stereotypical example that you'll usually hear about, especially like in your classes or on exams. And that's like a patient receiving slightly different care based on some aspect of their background, things like race or sex or socioeconomic status. However, the idea of justice actually encompasses a little bit more. It also applies to the norms for the fair distribution of resources, of risks, as well as of costs of care across society. So knowing this full definition, one could definitely see how Sebastian's actions, having his father kind of jump the line, could be construed as being unjust, and then by proxy, being unethical. Although Sebastian's father might not have ultimately received care that's different than other people, the distribution of the timeline of his care in terms of not having to wait solely based on the fact that he had a connection on the inside raises some ethical concerns. This same principle of distribution of medical resources along a timeline might seem kind of familiar to you with the rollout of COVID vaccines earlier this year. Especially early in that vaccine distribution process, there were a lot of questions that were being raised regarding the ethics of like unused doses being given to individuals who were not in the current target population versus those doses just being like discarded or wasted. That was, again, at the beginning of this year. But back to Sebastian, how do you think that he can undo this ethical slip up? So take a second to kind of think what he might do at this point. Here's what Sebastian did. Thinking about how his actions might have been unfair to patients who had been waiting longer for an appointment or may have had more acute needs, he actually asked the scheduler to remove his dad from the next day appointment slot and put him back in his place in the queue. Ultimately, his father had his knee replacement by the original orthopedist that he had been seeing, and he ended up having a positive outcome of that surgery. Sebastian realized that although that he had the power to help his family members and friends access medical resources sooner through back channels, by using principles of medical ethics as a guide, it might not be the best choice. As a side note, after graduation, Sebastian got hired by that world-renowned orthopedic surgeon, and he actually helped cut down the appointment wait time from 6 months to 2, because that's something we can do as PAs. So the next case is going to be Annette. Annette is a new grad PA who just started her very first job as a family medicine PA. While on orientation, she's actually sharing a clinic schedule with her supervising physician, who has given Annette pretty consistent feedback with regards to her ability to connect with patients and counsel them on things like health maintenance and test results and treatments, and also with initiating workups. So Annette just saw a perimenopausal woman who presented to clinic with irregular periods. As an initial step in this patient's workup, she ran an in-office pregnancy test, which ended up being positive. So feeling pretty confident in her counseling skills, Annette enters the exam room and says, "Congratulations, you're gonna have a baby." And then she proceeds to excitedly provide very sound and very comprehensive patient counseling on prenatal care. But the patient becomes a bit tearful, and she shares that this was an unplanned pregnancy and she is interested in information on termination. Uncomfortable with that situation and having never really understood why someone would choose abortion, Annette asked the patient, "Now, why would you want to do something like that?" I'm going to let that sit with you for a minute here as you ponder the ethical components of Annette's actions. So for our next poll question, it's going to be, what should have Annette done before providing the results? Should she have acknowledged her own biases, placed a referral to OB-GYN for prenatal care, prepare a list of things she should tell the patient to do now that she's pregnant, or share the result with her SP's medical assistant, who is one of Annette's friends? Okay, looks like most of you got this question correct here. I think this was the easy question of the bunch here. So we're going to think about beneficence for a minute here. As medical professionals, we are entrusted to act in the patient's best interest, period. This means that we must gain and develop and maintain competence in knowledge and skills and attitudes, and we must always consider the individual circumstances for each and every patient that we see, with the goal of doing the most good for that patient in front of us at that moment in time. So this is directly connected to a concept that I introduced at the beginning of the session, the doing away with the paternalism in medicine. So discarding the notion that the doctor or PA or other clinician is always right. So at face value, beneficence may seem like a no-brainer or kind of seem easy. However, in many instances, it is difficult. Sometimes we think that we know what the patient wants. In some instances, we let our own worldviews, our biases, and our belief systems seep into the care that we provide, sometimes even despite having the best intentions in mind. And that's exactly what we ended up seeing in Annette's case. And most difficultly, in some cases, it might be challenging to balance respecting the patient's autonomy while acting in their best interest. Perhaps one of the most important things to remember when it comes to beneficence, whether you're a student or a clinician or any point of your career, is going to be asking the patient what they want, and then actually listening, like actively listening to understand the patient's values and understand the patient's desires. Remember that just as we as clinicians face gray areas of difficult decisions, patients face them too. So let's rewind Annette's story and talk about how she might have been able to better demonstrate beneficence. So before she even entered the room, I would suggest that Annette should have acknowledged her own biases surrounding pregnancy. Thrusting your value system upon a patient is not doing good for the patient, especially in these gray area scenarios where difficult decisions must be made. Next, she should have asked the patient her understanding of the test that they were running and asked if she was ready for the results before disclosing the results. Then once she disclosed the results, Annette should ask the patient how she feels about them before moving on to any counseling or any management options or decisions. The key here, as you can tell, because I said it like 5 times, is asking. So ask the patient. Annette also could have asked her supervising physician to be more involved with sharing the results, especially if it's something that she's never done before, or if she may be uncomfortable with some aspect of it. Remember, she's still right out of school. She's still learning how to become a competent clinician, and she is certainly not alone. As a PA, you will be expected to have difficult conversations with patients, but doing so without checking your bias, without being fully prepared, and without knowing when you need to ask for support or guidance or help is also not doing the most good for a patient. Please remember that. So, with these corrective actions, Annette was able to provide comprehensive and ethical team-based counseling with her supervising physician, and the patient was able to receive the care that was right for her. So, final case. We're going to meet Blaine, who is on his final week of his surgery rotation. He really enjoyed his rotation and has thrived in the operating room, where he has been complimented on his suturing skills, and he always aces the medical knowledge questions that the surgeons pose to him during cases. However, Blaine knows that his classmates who rotated at this clinical site had the opportunity to assist with donor procurement procedures for organ transplant, and he's concerned that this opportunity may not arise before his rotation's over. On the second to last day of his rotation, Blaine comes down with a low-grade fever, a dry cough, and a runny nose. He also receives a text from the chief resident letting him know that there's going to be a procurement opportunity later today. So Blaine knows that he should not go to work sick, and that if he answers truthfully on his program mandated daily wellness screening, he's going to be sidelined for the last 2 days of his rotation. However, he really wants to be involved with the organ harvest and figures that no one's really going to notice that he's under the weather with what's most likely like a common cold or something, since he's going to be wearing a mask anyways. Plus, he really wants to impress the chief resident, who has really taken him under her wing during this rotation. So take a second to ponder and decide what's the most ethical decision for Blaine to make. Report to his rotation as usual. He may never have the opportunity like this again. Tell the chief resident that he would like to come just for the procurement. It's not like he's going to get his patient sick anyways. Stay home and alert the chief resident that he's going to be absent due to program policies, and stay home and email his advisor tomorrow to let them know about the situation. Okay, so it looks like most of you guys probably selected the right answer here of staying home and letting the chief resident know that he's going to be absent. I knew it was going to be evening and you guys would be tired. I gave you some easy questions here. So the last principle that we're going to be tackling today is non-malfeasance. And I like to call this principle the Hippocrates principle because at its essence, it's basically that tenet of do no harm. But what does that actually mean? And I asked that question, what does that actually mean? Because we all went into medicine because we wanted to help people, not harm them, right? So why do we even need to be reminded of this? It should just be there in the back of our mind, right? And that's the reason I ask you is because harm doesn't necessarily need to be direct harm. It can occur indirectly through things like imposition of unnecessary or unacceptable burdens upon a patient. Those burdens might be physical, emotional, mental, one that we don't think of that often, like financial burdens of the tests we order or the interventions that we prescribe patients. In Blaine's case, it's really kind of gray in terms of the patient that he might be harming by going to work while he's sick. That's because, as you can recall, he was actually considering going to an organ procurement. So this patient was at the end of his life or her life. However, by entering the hospital, he would be engaging with colleagues whom he may inadvertently infect with his illness, who may then spread that to others, including patients. And I'm going to totally out myself right here, right now to all of you, all 137 you that are here live and people watching it later. And I'm going to say this, that during pre-COVID times, I was one of the hordes of medical professionals who went to work sick all the time. There was this invisible pressure imposed upon us to do so. We didn't want to leave a shift open or have to call in a colleague or have to cancel patients off of our clinic schedules. I want you to think about that for a second and imagine all of the harm that we likely did to patients by passing our minor viral illnesses to them back in the day. And just kind of think about how crazy it is that it's taken a global pandemic in which we've become hyper aware of symptoms, and the word quarantine has become a household term in order to kind of denormalize this actually unethical behavior that so many of us engaged in because it was really part of the norm culture in healthcare. Anyways, off that segue and soapbox, we're going to go back to Blaine now. And I want you guys to kind of think again, what he could have done to act with non-malfeasance. You already answered that question. So I think that this is actually the most straightforward of the 4 cases that we presented today. It's also the one that's most likely that you're going to probably encounter when you go on your clinical year or when you get into clinical practice. It's also, out of the cases that I've presented here today, the most tempting to act in a way that's potentially unethical. So obviously, like we said, Blaine should answer his program's wellness screening honestly. He should alert the chief resident that he's going to be absent due to policies and that he'll unfortunately have to succumb to a little bit of FOMO or fear of missing out on an educational clinical experience because it was the right thing to do in terms of harm reduction for patients and to others in the hospital. So those are all of our cases. In summary, I really just want to drive home 4 major points regarding ethical behaviors in medicine. The first, remember that there's a lot of gray area in medicine, especially when it comes to ethics. It's rare that there's a clear-cut right or wrong answer. Even as a student, there might be some instances where you have to choose the least wrong decision, or you might find yourself kind of unintentionally sliding down a slippery slope of unethical behavior, even when you had the best intentions in mind. When you're faced with a potentially tricky situation, please let the 4 major principles of medical ethics be your guide. Ideally, for an action or a decision to be ethically sound, it must respect all 4, and those include autonomy, justice, beneficence, and non-malfeasance. Remember that you are not alone. In medicine, we've all made mistakes, and we're all faced with making difficult decisions each day, many times with ethical implications. When you're still medical novices, it might seem like this comes really naturally for experienced clinicians or your professors or your preceptors, but I really assure you that this is far from the case. We struggle with these conundrums and oftentimes kind of pull in the collective brain power of our peers, our collaborating physicians, and sometimes even our interdisciplinary and institutional resources, such as things like hospital ethics committee. None of us are alone. Please remember that. And the last thing that I want to say is that you should never hesitate to ask for help. And this help can come from preceptors, from faculty advisors, clinical coordinators, peers, and even specialized groups. And this ask for help can come at any time, whether you are contemplating the ethical merits of a decision before you take action, or after you've realized that you've potentially made an unethical mistake and you need to make it better. Those 4 points I really want to drive home. So I want to thank you all for your time and your attention for tonight's presentation, When Good Intentions Go Bad, Stories in Medical Ethics. I have included my contact information here if you have any follow-up questions or if you want to have a conversation to further discuss any of the topics that we covered today. So I want to thank you, and I am a professor that is always respectful of my students' time, and we have finished early. So I'm going to go ahead and stop sharing my screen at this point. And we'll see if Katie has any questions in the Q&A for us to go over here.
Yes, so we've started to get some really great questions in, and please, to everyone out there, we have time for a few more questions, so please put them in the Q&A. So 2 people typed in at almost exactly the same moment, and I think this is a great question. How do you address these ethical issues if it happens by a coworker or a physician you're working with?
Yeah, I mean, I feel like this is something that you're definitely going to, you're gonna see this from time to time, and I think that stopping that in the moment or like acknowledging it in the moment is something that you should definitely do. I'm actually trying to think of the acronym right now because I actually just had somebody share this with me. There's I'm forgetting what the C stands for, but if you do like team steps, which is like a hospital-based kind of like a program, there's something called like the CUS protocol, and it's basically where you can intervene when you see somebody that might be doing something that is unsafe, excuse me. So this is something that I personally want to integrate in when I see maybe unethical things happening in real life. I forget what the C stands for, but the C is basically saying like, I see something happening here right now. The U stands for, it makes me feel uncomfortable. And then the S stands for safety. And you could say like, I feel like this may be a safety concern. So it might have to do with patient safety. It might have to do with like psychological safety. So maybe if anybody wants to share in the chat, if their team steps trained and they know what the C in the CUS protocol stands for, please tell me right now. But I think that
says it stands for concern.
Concern, there we go. We have very smart people in the crowd here. Again, for help, role modeling right there. I know what I don't know. But I think that's something, a lot of us kind of naturally do that when we see something going down that might not be ethical, that might be unsafe, that may be like even, an act of bias by some of our colleagues too. But I think that's a nice scaffolding that you can use to kind of like script it out. And it also just gives a nod to the fact that you're feeling uncomfortable with that. And these are uncomfortable things to talk about. And so, even acknowledging that when you confront somebody can be very helpful. I hope that answers your question.
The next question gets to this issue that you discussed about sort of acknowledging a patient's own values and cultural competencies and cultural values. If a patient, specifically a pediatric patient who is a Jehovah's Witness, needs a blood transfusion, what would you do, or what are the ethical issues to think about there?
I feel like this is one of those kind of, I don't want to say stereotypical, but like very common what ifs that kind of comes up here. Honestly, with these, you do have to respect people's value systems. But when it's a pediatric patient, things get much more gray in terms of gray area. I personally never encountered a situation very specifically about like blood transfusion, pediatric patient, Jehovah's Witness. But I think that this is an instance where, especially as a PA or really any healthcare clinician, where you should ask. And that's one of my major points, like don't be afraid to ask. And the people that I'd potentially ask in this instance would be, collaborating physicians or the attending on the service. And then, if somebody needs a blood transfusion, they're likely going to be in a hospital. Hospitals have ethics committees, and sometimes we do need to get these ethics committees involved, even kind of like on more acute terms. Like I have consulted the ethics committees at more than one hospital that I have worked at, and they are often very happy to provide sometimes a very academic and kind of drawn out, advice for things. But this would be an appropriate instance where you should ask. I'm not going to give a blanket answer as to like, you should definitely, go against the parents' wishes and do, what's medically right for the child and, give them a transfusion, that type of thing. And I'm not going to say, oh no, you have to, do what might be medically wrong for the child and, respect the parents' wishes here. I think, again, this is a very gray area issue. I think it's going to change based on case to case. But I think, kind of the takeaway from this question is going to be, don't be afraid to ask and know who you can call on.
Makes sense. Next question. It seems that some of these ethical dilemmas are related to the medical system as a whole. One example you mentioned was non-malfeasance, financial burdens of the tests we order. As providers, how should we navigate this with the patient's best interest?
I love this question, and we work in a broken system, as we've already kind of made a nod to here. So my answer is going to be kind of at least 2 points. Maybe I'll ramble on to more than 2 points. The first point is advocacy. And so, that doesn't help you when you've got a patient sitting right there in front of you in the moment. But it can help maybe fix the system, and maybe we won't fix the system entirely. But I think that, if you can, make small differences over time, that's good. And so I would highly recommend that this is something that you're concerned about, becoming an advocate for change, for increased coverage, for price transparency, which is something that has seemingly pretty like bipartisan support pretty widely in the United States right now when it comes to like price transparency of medical costs. And so I think that that's something that we do need to remember, is that we can be advocates for change in the healthcare system. So that's part one. Part two is just having transparency yourself with a patient and using shared decision making with a patient. And so, there may be times where, like you sit down with the patient and say like, these are like the two options, for treatment. This one's like the gold standard, but if you look at the medical literature, like this one's like a little bit worse, but it's much better in terms of like financial costs. And, of course, if one's like much better and the other one's worse, like then that gets into an issue of being unethical. Like if you give somebody subpar treatments because they can't pay for it. But if things are like, neck and neck, they're pretty much the same, like having a shared decision making conversation with your patient so that you're not putting them in complete financial ruin in order to treat them. So I think, advocacy and transparency along with some shared decision-making with your patients is going to kind of help you stay on the right side of ethics there.
The next question, would it also be unethical to make residents and providers work over 55 hours a week? I don't think sleep-deprived providers would be able to provide high-quality care to patients.
Oh my gosh. I would have to think about this one harder in terms of the idea, like the actual ethics and like ethical principles that would be broken here or breached in this instance. Part of me, I feel like this would be like a fun question to like actually have like a real discussion, not put somebody on the spot with that, because I want you guys to take what I say right now as the gospel pretty much and say like, oh, Janelle Bludorn says that this is definitely unethical. I think it bounds on definitely unethical, but I think it's an issue kind of the system right now too. Should people be working and, be entrusted with, life or death decisions when they are sleep deprived and stressed and burnt out and that type of thing? No. Again, going back to advocacy, like trying to change those things. Absolutely. I'm sorry, I don't have a good answer for you here. I wish I did. I think I can give you my opinions until I'm blue in the face on this, but I would really have to kind of sit down and think more deeply on kind of the objective ethical principles that would be breached here and kind of think of it from all angles.
I think that makes sense. And it's a little outside of the scope of the presentation, which we've sort of focused on from the provider perspective, how you're practicing in your clinical encounters. So I think that's fair. Next one, what are the possible repercussions for making unethical decisions as a provider?
Oh, there are many repercussions at many different levels that could occur. One could be having, poor patient outcomes and that being shown on like, metrics within your healthcare system or what have you. Another one could be where the ethical dilemma or the ethical principle that was breached actually parallels a law in which a law would be broken. And so there could be legal implications in terms of like the criminal justice system. And then finally is in kind of like the civil justice system. So I do quite a bit of medical legal consulting in which I review cases like where especially PAs are being sued or have active litigation against them because of the way that they managed a patient or worked a patient up or missed a diagnosis or what have you. And it's not uncommon for there to be undertones of ethical breaches in some of those legal cases. And so, I mean, in short, you could get sued is what I'm saying with that. And so there are a lot of different repercussions kind of in these different, buckets in terms of like at the institutional level in the legal system on a criminal standpoint or legal system on the kind of like a civil suit standpoint.
Definitely. And in my limited experience with this, having worked with PA students, I know a lot of PA students are in the audience here. I've actually spoken with students who were excused from their programs in their clinical rotations for scenarios very similar to the first scenario that you told tonight, where they posted on some social media or did something that violated HIPAA, for example. So they're in addition to this sort of like career, you could literally be excused from your program.
Or fired from your job, and that's kind of that first bucket that I was talking about. There's kind of at the institutional level, there can be repercussions. And I'm glad that you brought that up, Katie, because all of these cases are ones that I have experienced either directly or indirectly through many of them are like, based on a true story situations. Obviously, there's a lot of details changed in these, but a lot of the inspiration for these are drawn from stories I've heard or stories that I have had a peripheral involvement in.
Next question, is it ethical for clinicians to promote products on social media given that they are being paid to do so?
This is another one where I feel like I have an opinion on it, and that opinion maybe is not, I would need to check my biases and try to decouple that from the kind of like the more objective measures of our ethical principles here. I think that it kind of depends on the way that these things are being promoted or marketed and who they're being promoted or marketed to. If there is a conflict of interest, like maybe where the clinician gets like a kickback or something like that, and they're directly promoting it to their patients, or they're promoting, you know, something to their patients as like part of a treatment plan, and then it's being promoted on social media and they're making money off of that as like an influencer or something like that. I think that there's definitely some merits of that being unethical. You know, so I think, yeah, I think I would have to know like the specific situation and kind of the context of all of that. And I'd really have to actively work on decoupling my personal beliefs and biases regarding these types of things from kind of the objective metrics. Good question though.
Here's a new scenario. If a
great.
patient came to the ER for breathing issues with a known history of drug use, so the medical team took a urine sample, we find out that she's positive for opiates. We also know that she has small children and that she is the sole guardian. Are we obligated to report, or have we tested her urine unnecessarily?
Well, I think that there are two questions in this. You know, you may have tested the patient's urine unnecessarily. I think there's probably more about the history or kind of the case at hand that you would need to know. I think like a lot of times, especially in the emergency department, people order urine drug screens for patients that don't need urine drug screens. Like the patient told you that they, you know, took a bunch of heroin. Like, why do you need that? You know, why do you even need that? So I think that sometimes we do order unnecessary tests, which can be an ethical dilemma in and of itself. And so I think, you know, there's one issue there. In terms of whether you need to report or not, that becomes more of a legal issue, and that legal issue is going to vary from state to state in terms of like what you need to do in terms of reporting, like what types of behaviors need to be reported to state organizations or like Child Protective Services. I'm somebody that has worked as a PA in 3 different states, in California, Massachusetts, and now North Carolina. And each time I move states and get my PA license in a new state, I really try to familiarize myself with the laws in that state, and then also make good connections within the healthcare system that I work with like social workers, you know, with, you know, some hospitals. I've worked in a lot of academic medical centers in which there's kind of like specialized groups of like social workers, case managers, nurses, and even clinicians that kind of help manage these types of cases and can be resources. A lot of times they carry a pager. You can ask them these types of questions. So really try to familiarize yourself with what the laws are in your state to know whether or not that's something that needs to be reported, because I think that I've already mentioned this, sometimes ethical dilemmas parallel legal dilemmas too. And so sometimes if something's unethical, it may also be illegal. But sometimes something's unethical and it may be perfectly legal, or maybe, you know, any of those types of combinations of things.
Next question, do you have any ethical cases regarding macroaggressions or verbal abuse against students from preceptors?
Microaggressions, I wonder if they mean microaggressions. I don't off the top of my head, but now I want to make one. I don't have a case right now. I think that it would be an excellent case, because I think that this is a really important topic right now. And I think that it really kind of dives into this idea of power differentials and people using power to discriminate or belittle people that have lower power influence than them. I think this is something that, I mean, we see it in healthcare, we see it in education, you know, it's actually seen across, you know, many different industries too. And I think that it's something that's been happening for a long time. And I'm really happy that now there's more attention being turned towards it. And hopefully, you know, now the attention is being turned towards it, hopefully there can be some remedy and ramifications for that.
Okay, next question. Do you think there'll ever not be a pressure to come into work when you're sick? When I worked in the hospital, there was pressure to still come to work, especially if your COVID test was negative. How can we encourage an environment that allows providers to stay home when sick?
This is again a point of advocacy, I think, here too, and not just advocating kind of on a macro scale, but advocating for yourself, for your wellness, for your well-being, and then by proxy for the well-being and wellness of your patients and your coworkers too. I think that one of the biggest things that can be done to kind of remedy this system is people who have, power, influence, status, role modeling these types of behaviors in terms of, normalizing staying home when you're feeling unwell, even if you have a negative COVID test, kind of normalizing taking time when you need, time because of illness or stress or what have you. I think that this is something that, again, people that have status should be the ones that do this role modeling. If you're not at that point yet, be sure that you advocate for yourself. You can always, once you get working or what have you, you can, work on like policies within your healthcare system or within your clinic, and really kind of package it in a way that it's what's best for everybody.
Next question. Do you feel that there are particular ethical considerations uniquely relevant to the PA role within healthcare?
I think that, I don't think there's any like one of those 4 ethical principles that's going to be, that jumps out more than the others in terms of kind of like the PA role. But I think that when it comes to ethics, I'm going to go to those one of those 4 main points that I highlighted at the end of my presentation. And one of those 4 main points is actually 2 of them, knowing that you're not alone. And number 2, and the other one, knowing when to ask for help and actually asking for that help. I say this as a PA educator because that's been practicing for more than 10 years, is that we are charged with giving you an insane amount of knowledge and skills and attitudes in the 2-ish years that you're in PA school. We give you a ton of information. You guys get a ton of information in your head. However, with 10 years of practice, I know that there's a ton more information out there that you're only going to get with being a lifelong learner and kind of having that exponential growth of knowledge, skills, and attitudes after you get out of PA school. You're not going to just be able to like read a book or like look on UpToDate or what have you. You have to be able to know your limits and know when to ask for help. So I have seen PAs get into difficult ethical dilemmas when they do not know what their limits are in terms of like where their knowledge set is at that point in time. And I'm not saying like, we're completely limited, because like PA, we can see, the sickest patients, we can see, complex patients, that type of thing. But we need to know when to ask for help. And so I have seen, and kind of like understand, when you need to get your team involved. And so I have seen PAs get into sticky situations, and I would say that bordering on ethical when not understanding when to ask for help.
Answer. Last question for the evening, and I think I want to make sure we're thinking about this through an ethical lens. So if you suspect abuse, but the patient has not outright supported your suspicion and the abuser is in the waiting room, what do you do? And what are the ethical issues at play there?
I mean, I think that obviously I think any of those ethical issues, all 4 of the main ethical principles do apply at that point in time. And you potentially may breach some of those, or you may kind of act in an ethical manner with that. And you could probably argue either way, depending on how you're deciding to act in this instance, or kind of what actions that you're going to take in this instance. I do think that this is another instance in which it's going to depend on the laws in the state in which you're practicing. And I'm not a lawyer, and I don't practice medicine in all 50 states and territories. So I don't know what law is going to apply for you, and it kind of depends on what the type of abuse is. Is it sexual abuse versus physical versus verbal versus child abuse versus elder abuse, what have you, because there are different buckets of laws with all of those instances. But I think that through a purely ethical lens, you do have to kind of think like, what is the just thing to do? What is going to, not have harm come on to this patient here as well. So I think it's a complicated question, and I think that it's really going to be dependent upon the circumstances surrounding.
Thank you so much for those thoughtful responses. I think this is one of the most interesting Q&As we've had, and really a lot of provocative things discussed. And the stories that you shared in the presentation were so relatable. And I really think this was a valuable discussion. So thank you for that. And thank you all out there for joining us on a Wednesday night to talk about medical ethics and really how we can be better providers and really ultimately better patient providers. I've shared the link in the chat for the feedback survey. We'd love your feedback on this webinar session and your ideas for future sessions as well. The next PA Like a Pro webinar will be held on November 17th at 8 p.m. Eastern, Conquering Imposter Phenomenon. You'll learn what is imposter phenomenon and really how PA students and early career PAs can identify imposter phenomenon and strategies you can use to combat it and improve your confidence in both clinical and academic situations. I think it's going to be a great discussion, and I do hope you'll join us. We should have registration live up tomorrow, and we'll send that with your follow-up email that you'll get after this session. So thank you again, and have a wonderful night.
Thank you, everybody.